Thanks. I'm excited to be here. Thanks for the invitation. Thanks for the chance to meet everybody, people I can catch up with, and new people as well. Just disclosures, we are part of the clinical trial for Vanishing White Matter Disease with Calico. I think that's the only relevant disclosure. So VWM, or leukodystrophy with Vanishing White Matter Disease, has been around for, has been recognized as a disease for a couple of decades now. It's also been gone under a couple of different names, including CACH, as well as Cree leukoencephalopathy in a native Canadian population. It has a very profound imaging appearance when at a CT even or MRI, the white matter has a really high T2 signal, which is just really looks terrible. Oftentimes the patients are doing better than the MRI looks, but it does look terrible when you see that MRI. And then over time, as the disease progresses, the white matter tends to cavitate out, and hence the term vanishing white matter disease was proposed in 1997 by Mario van der Knaap. So it is a genetic disease. It's autosomal recessive. There's a group of 5 genes, the EF2B subunit genes, that are responsible for the disease. It tends to be inherited where both each parent is a carrier and then has an affected child. So, so again, there's 5 different genes. They make up this dodecamer EF2B complex. And this EF2B complex has 2 major roles in cells. So the first role is that it is necessary for protein translation. It's something called a GEF. And although there's probably a component of vanishing white matter disease where translation is affected, its primary disease effect is probably related to the second thing, this thing called the ISR. The ISR is the integrated stress response, which is something I'd never heard about until about 5 or 6 years ago. And so basically, you can think about like in our own bodies at a person level, if you get stressed, your cortisol goes up, your heart rate goes up. Same thing for a cell. When a cell gets stressed because it has less oxygen or has less glucose, it needs a protective response, and that's the ISR. So it's supposed to turn on the ISR if the cell's under stress, and turn off the ISR when the stress goes away. But what happens in vanishing white matter disease is that the ISR is chronically on, and just like it's bad for our bodies in general, it's also bad at the cellular level to have the ISR always turned on. So there's really nice natural history data that's been primarily from the group of Van der Knaap in Amsterdam. And the key point is that there is a genotype-phenotype correlation kind of loosely, and that genotype-phenotype correlation then links to the age of onset. And the earlier the age of onset, the worse things are. And so if you have onset in the first, either like at birth or pre-birth or shortly after birth, you tend to have a high risk of rapid progression to death in the first couple of years of life, whereas there are also people who don't have disease symptoms until their 30s or 40s, and then they have a very slow progression. And so that's what these different curves show, just the different rates of disease progression. So over the past, I'd say 5 years, there's been a lot of work in the field. So it's been great to be part of that. There's a lot of work from something called the VWM Consortium, and they've worked on, which several of us in this room are part of, as well as really been led in large part by Mario van der Knaap in Amsterdam. And there's kind of key things that are now kind of recognized for management of vanishing white matter disease. So there's kind of standard disease management, which really makes a big difference in patients' lives. I think one really key point that I've seen multiple times in patients I've taken care of is that seizures seem to be really bad for patients. I'm not sure if it's a chicken or an egg problem in terms of which came first, but a pretty aggressive seizure control, I think, is really important. So there are a set of clinical management guidelines coming out, hopefully imminently here, with some sort of general recommendations. They are moderately evidence-driven, and so there is some and so there are kind of recommendations so that families kind of know what to be thinking about in terms of like avoiding head contact sports, or trying to be moderately aggressive with avoiding fevers or infections. There's also instructions as well as for physicians. There is some data that inhaled anesthetics, anesthetics of the inhalation class are bad, whereas like propofol seems to be safe. And so these recommendations should be coming out shortly. Again, there is some data, but it's also a lot of it kind of expert level opinion, which you can kind of take or leave depending on what you think. So there's been a lot of research as well in the past 5 years, I'd say, that's really kind of moved the field of therapies forward. So there's been work on AAV9 gene replacement therapy that's included work from Amsterdam, from Mario van der Knap and Nick Van Til. There's work from ourselves in collaboration with Alison Bradbury at Nationwide Children's Hospital. There's also work from ourselves and Alison Bradbury looking at microglial transplant. There's small molecule development from Calico as well as several other companies. There's been work in vivo base editing. There's work in CRISPR. So those top three things are all active projects. And I'll be talking a little bit about the first three ones. The in vivo base editing and the CRISPR currently seem to be not progressing. They've just run into various technical difficulties. So the key observations that have really helped drive therapy development, in addition to the recognition that the ISR was the key disease pathology, is that astrocytes seem to be the kind of the key cellular player in the pathology. There's also some data that other cell types may be important as well, which is not surprising that one bad cell doesn't define everything, but astrocytes really seem to be important. It's been also nice work on using mice to look at disease. And so the kind of the key phenotype is that the mice are ataxic and can't stay on a rotarod that well. And so the phenotype is to kind of look at the mice over time and see if they can then respond to treatment and stop falling off the rotarod. So in work of our own lab with Alison Bradbury's group, we developed a series of gene therapy vectors to try and treat the disease. And at age 6 months in the mice, we're like very excited because the mice with disease who are treated with gene therapy were staying on the rotarod that I just showed you. But over time, that efficacy kind of gradually tailed off, so to speak. And we've done various work now kind of going forward to try and improve that therapy response to see if we can get a more sustained response in the gene therapy. More recently, we've also been looking at the involvement of microglia because astrocytes and microglia have this kind of unholy relationship with each other. It's not a natural relationship. No, I'm kidding. So there have if a astrocyte's doing okay, but if you have a bad microglia around, the microglia can set the astrocyte off. And so looking in the mutants, we do see that the mutants have a lot of activated microglia in the brain, and that's what these really bright green cells are, for example, here in the corpus callosum, and this is like a count of all the bad microglia. And so now we're looking at using microglial transplant with or without the gene therapy to see if we can get a more sustained response. And so, there's movement from ourselves with Alison Bradbury's group. There's movement in Amsterdam on gene therapies. It is looking really promising, but of course, again, it's just in mice. You don't know until it reaches the person. And we're really hopeful that maybe in the next year or two, one of these therapies will be able to move forward into clinical trials. And so that's involved a lot of work from a lot of people. So let me move now to things that are actually in clinical trials. And so all the current clinical trials are based on the concept of inhibiting the ISR, the integrated stress response. And so the trials include a trial in Amsterdam using a medicine called guanabens. That trial, the enrollment's complete. The results and data are pending. I'm not sure, that's not been, I don't think the unblindings occurred yet, so we haven't seen any results. So we're excited to see how that's worked. I think guanabens is basically a repurposed drug. And so certainly I think patients have, I think it's, again, this is all anecdotal, but it seems to have like maybe slowed disease progression, but I think it also comes with kind of moderate side effects, especially in younger patients. So it's better than nothing, but I think we're still waiting to see how the results look. There's a medicine called fossigatifator, so it's kind of a mouthful, developed by a company called Calico. I'll be talking mostly about that one. And finally, there's been a compassionate use protocol for something called prodopidine. And again, I think that's mostly been kind of a disease halting type approach. So just to remind ourselves, there's different phases of the clinical trial. And as I'm talking about fosgonimeton, it started with a phase 2 trial, now moving to a phase 3 trial. And I think because of how well the trial's been going, Calico, the company, is really trying to move forward more rapidly. So the next set of slides is all from Calico. So Bill Cho from Calico has graciously allowed me to show these slides. So Calico, so again, it's obviously the company is kind of advertising itself here, and it's not clinically approved, and it's an investigational drug at this moment. So the drug was based on a bunch of basic science data on a compound called ISRIB, and ISRIB was found to bind to that big dodecamer complex and to stabilize it and to basically shut off the ISR. So then the EF2B complex could work normally. And there's been like a lot of great work from this group, primarily from this scientist Carmela Sidrowski, starting in 2013 and going on now for more than a decade. So the medicine is a prodrug. It's oral. They build it as an oral use. It's a solid. It basically looks like pop rock, and it's water soluble. And so it's tested first in healthy people, seen to be very well tolerated, and it crossed into the brain such that it could have an effect in the brain. So the initial trial was started as a phase 1b, so basically just testing safety in adult patients with Vanishing White Matter Disease. And those first 4 patients did totally fine. So even though here it says generally well tolerated, they were like 100% fine. All their lab tests were fine. There weren't any problems. And then even though it was kind of set up as a safety trial, the patients were doing better than when they started out on the drug. And so at this point now, the phase 1b is expanded into a phase 1b/2 trial. It started out very small, and it's expanded now with larger cohorts with different ages of cohorts. And so now it's done all the way down to 6 months of age. I can just say personally that we've been struggling to enroll as fast as we can to get patients in. And it's very exciting. Patients are kind of showing up out of the woodwork to enroll, and the trial is going well. So all the safety data has been great. The study centers currently for this phase 1b/2 study are ourselves at Utah, the Van der Knapp group in Amsterdam, and then Mass General with Florian Eichler. I think this summer, CHOP is supposed to open, and McGill in Canada is also supposed to open. And then with the trial going well, there's also a move now to open a phase 2/3 trial, hopefully later this summer, or probably realistically late this year, which will be across the world. So 25 sites. It's going to be quite large. So that will be happening, I'm hopeful, later this year. So the phase 2/3 study has different criteria than the phase 1b. For the phase 1b/2, you had to be quite severely affected, either not able to walk or have a very affected IQ, whereas the phase 2/3 is looking more kind of at efficacy. So you have to have milder disease, meaning you have to be able to walk 10 steps or more and have an IQ, and I think the IQ cutoff was 80 for this. So that's the data from the Calico group. It's all still not been reviewed formally, but I can just say personally, I'm very, very excited about it. So I'm really optimistic this will be a real game changer. I think it's going to be a game changer not only for Vanishing White Matter Disease, but I think for other leukodystrophies as well. So we are excited then to kind of summarize all this. I think the guanabens data will be nice to see that data. Hopefully later this year, those results will be coming out. Fosgonimeton is moving quickly. It's looking really promising. I think, again, it's a little bit hard to know. Calico tends to play their cards quite close to the chest, but I could imagine them going to the FDA sometime in 2026 to try and get an accelerated approval. There's been a lot of people across the world involved in the work. I think some great work from Amsterdam and the Van der Knapp group. I think the VWM consortium has really helped push the field forward with kind of organizing the community about how to do these trials. And that's been so important. And then finally, like our groups, we've been really fortunate to have like really great collaborators to kind of work on developing the next kind of generation of therapy for vanishing white matter disease. And thanks for the chance to talk.